Okay, everybody. We have quite the guest today. I officially met like 2 milliseconds ago, and well, maybe slightly more than that when we went to start recording. But if you're on LinkedIn, I highly recommend that you go follow our guest today because she provides a plethora of information on that platform. So please allow me to introduce a NICU physical therapist that actually does feeding because it's within her scope of practice, the one and only Miss Kati Knudsen. Did I do it right?
You did. Thank you so much.
I spelled it phonemically over here on the side just to make sure. Because again, I teach
I love
ladies,
it.
I'm not the Arctic therapist. But um, Katie and I had a quick sidebar conversation because we want to make sure that everybody is truly ready for today's talk. Physical therapists have a place in the NICU. That is well established. But physical therapists can also work with pediatric feeding and swallowing disorders in the NICU, which, let's be honest, I know a lot of SLPs that get real territorial about an OT doing feeding and swallowing in the NICU. So if we were to transition and add in a PT, I could see how some folks might get their panties in a twist. But I say this because that's why we have these conversations and have a scholarly space. We need to embrace interprofessional education so that we can improve our interprofessional practice because at the end of the day, we are all teeny tiny human, the little ones that we've been called to serve. So, Katie, on that note, hi.
Hello. Thank you so much for having me, and I agree wholeheartedly with what you just said. So thank you.
Thank you.
Let's just
Well,
level the playing field right at the beginning.
we're just going to set the stage. I got to be honest. The first time I heard about a PT in a NICU, I was out in California lecturing, and I was lecturing, but for like toddlers and children. And there was a room full of physical therapists, and they were like, "You don't work in the NICU?" I was like, "Oh my God, no! Those babies are too small. My babies were in the NICU," and they'd signed up to take my class because they needed to take continuing ed because they were going to start. And that was my first experience meeting physical therapists that worked in the NICU for feeding.
Okay. Wow.
That was probably Bears 11. So that was 9 years ago
Okay.
because he was 2. We thought it'd be really good for mommy to start traveling during potty training.
Oh yeah. I'm sure your partner loved that one.
Yeah, Mr.
Your
Dawson over here.
co-parent was probably real excited.
Yeah, he was not, but we figured it out.
Oh
But
well.
how did you decide to become a physical therapist?
So I actually was pre-med almost all the way through college, and I'll age myself, but I was in college in the early '90s, and I practice in Portland, Oregon, still, which is where I was born and raised. I did leave and come back, but this was when HMOs were first starting, and a lot of people may not know the history of HMOs, but they were started in Oregon. HMO Oregon was our state medical plan for a while, and that was one of the very first HMOs. It was kind of a pilot program, if you will. It was started by the governor of Oregon, and Hillary Clinton did some work with that. There was a group called the Jackson Hole Five. Anyway, it was a group of 5 that met, kind of designed this program. So the reason that impacted me personally was because I had always thought I'd be a pediatrician, and because of the way the medical field was changing, I felt like if I'm a pediatrician under this model, I'm not going to have the interaction with patients that I want. I'm not going to have that relationship with children. So I started to kind of look at other fields. I looked at nursing as well, and that just didn't feel like the right fit. And I had, up until that point, I was a junior in college, didn't know that PTs could work with children, which I know sounds ridiculous, but that was my frame of reference, was all that PTs worked in nursing homes.
Yeah.
So worked with the elderly, and that was just not where my passion was. So once I started to realize I could do something different, PT started to feel like a good fit. I've also I've been very active my whole life. I love health and nutrition, and it just felt like a nice fit in that regard.
Nice. So where did you go for your physical therapy degree?
So I went to University of Southern California. Fight on, Trojans. And I still remember, well, first of all, I made my experience as pediatric focused as I could. So I literally pushed back against the, when we were doing clinical placements rather, I was like, well, this is a pediatric burn unit, and this is pediatric neuro, and this is pediatric ortho. So they're all different.
They
So they
are.
did let me do numerous pediatric rotations once I kind of spun that. I did, my master's thesis, and every paper I could do, I tried to do it more pediatric focused. And I still remember the lecture where one of our professors was talking about infant reflexes and showing slides of babies. And it was amazing for me. I was like, this is what I want to do. Like, you can just work with babies. That's amazing. That's what I want to do.
That's how I found out I wanted to do feeding and swallowing. I sat in the dysphagia class and I watched them. It was an adult modified because I thought at the start I wanted to work with adults, which is hysterical because now I think I would gag if I had to do like oral cleaning or anything like that. But at the time I was like, this is what I wanted to do, minus the one very large panic attack when I thought I should go back to school and be a lawyer because I love advocacy and fighting. But somehow or another, we've turned the podcast and given it plenty of opportunities for advocacy. And I'm like,
Sure.
this is how I can meet my therapist clinician soul and, fight for system and, yeah. So yes. Okay.
Yeah.
So you pursue the pediatrics and then
Mm-hmm.
you go into the world, but
Mm-hmm.
how into feeding and swallowing?
So I was hired into a large health system in Portland. What was interesting was I was hired to do acute care adults, but when they looked over my resume, they said, wow, we actually need someone to help in pediatrics. And I was like, here I am. And that was my whole goal, was just to get my foot in the door. At the time, it was really hard to get hired straight into pediatrics. So I started doing outpatient, but it included NICU follow-up clinic. And then I was also working, we have a long-term care facility for children in Portland who have severe needs, severe disabilities, severe medical needs. And so I was doing a lot right from the get-go in terms of positioning and looking at posture. And I had a pretty strong background even as a student in that, and working in tandem with the SLP on, how do we get, if we're going to do PO trials for a 12-year-old with, with CP, severe CP, how are we going to get them as well positioned as we can to make this, go as well as it can? So starting to already kind of think that way from the beginning. And then, sometimes to get into the NICU, you're in the right place at the right time.
Yes.
And so,
There's same to
yeah,
be said for SLPs. It's like bloody
right,
impossible to get in. Yeah.
right. So I was already doing a little bit of support because I'd started in follow-up clinic. I was doing a little bit of positioning support with older babies, helping with car seat stuff in the clinic, in the NICU, that sort of thing. And then we had two therapists that were working there primarily. At the time we had one NICU, now we have two in Portland. One went out on a medical leave and the other one adopted a child at the same time.
Oh my God.
So there I was, right? So it was me. So then they put me through some advanced training quickly, which was very helpful. And we modeled our program off of a big children's hospital to our north. And they have always had OT and PT sharing feeding in the NICU. So because we'd modeled our program off that, that was kind of just the way we fell in. I will say that we do have all three disciplines in our NICUs now, and that's ideal, I think, to have all three. But I think there's still a way to collaborate and share the load that helps the whole team.
Yes. Okay. So, folks, for frame of reference for when we're recording this, because it'll be a couple weeks before it's released, last Friday, the federal government and president decided to shutter basically all of the Department of Education, Special Needs, and Disability office. That being said, there was an injunction this past week that said those, I think the words furloughs have to be stopped. But this immediately following after the significant insurance changes this past summer with the passage of that bill. I myself, and I know a lot of colleagues, are very trepidatious as to what's going to happen to the allied health world when it comes to providing services for these kids. And just like you said, where all three should be there, we should be working together. But steeping yourself and taking the time to carve out mentorship with colleagues in the event that we transition to primary provider model, which I know a lot of EI systems and like the EI system that I work in already does that. Like, this to me is key because you know secret positioning things that I don't know. And that is huge when we're looking at those first hunger cues for, like a root reflex. But what if the child has torticollis? I can recognize the signs of torticollis. I don't know how to treat that, but I just say this because please, please, please listen to her words and go at this with an open heart, because how we practice today may not be how we are practicing in 2 years from now. So I just feel compelled to put that disclaimer in here at this moment.
I appreciate that, Michelle. When I talked about the beginning of my career, well, kind of coming into my career partly because of what was happening in the healthcare landscape at the time. If someone had told me HMOs would be dead 10 years later, right? There's still a couple out there. I shouldn't say they're dead, right? But that would not be the primary model 10 years later, that we would shift back to this PPO model. I don't know what I would have done, right? But that's the point. We can be proactive, but we still have to be able to be responsive and reactive to what's happening at the time.
Yeah.
So kind of following up on what you just said, I will go in. I am a certified lactation educator, which is an old term. It's sort of an older term. It's still out there. Basically means I did the CLC course but didn't take the test because it was back in the day. But long story short, I've helped with a lot of breastfeeding. And I feel like with my training as a PT, when I go in to help a mom with breastfeeding, I immediately look at mom's posture and the way, and especially in the NICU where she is learning as well, right? Like, I look at her and I immediately think, you cannot sit like that 12 times a day. You cannot.
No.
So, I think that's where, things are different. I'm going to miss some stuff that one of my speech paths is going to see just more intuitively. And that's where we're going to work together. So we do a lot of combined evals, like I'll go in with lactation or they'll go in with lactation, or I'll go in today and SLP will go in tomorrow, and we'll confer on what we're seeing with the baby, that sort of thing, so that we can pull all the information together.
Yep. Okay. So one, can you talk us through like the specialized training that you took? If there was like specific classes, or what does that framework look like for physical therapists now? And then I really want to know, what does an eval look like for you?
Okay. So obviously went to PT school, got out, started working, started taking courses. I immediately went beyond. I guess especially when you're talking about NICU, but even when you're talking about infants and toddlers, there are not courses really that are PT specific, right? They're either kind of motor, and so you're with OT and PT. They're more feeding, so you might have OT speech and some PT. Again, I think some of this is regional, where, we draw this model from the Northwest. There are definitely PTs feeding in my city and in Seattle as well. Some parts of the country, California is pretty heavy OT, and there's less SLPs. And then I also work with a lot of Canadian NICUs, and they're almost entirely OT. And then you'll go some places and SLPs are the only ones doing feeding. So I think there's just a lot of variability. And I know that didn't answer your question directly, but really, like, when have we ever gone to a course and had it just be our discipline if it's focused on infants and toddlers, right? Never. So I've kind of taken all the big ones, right? I took a course from Joan Arvidsson. I took a course from Marjorie Meyer Palmer. I took the Sophie with Aaron Ross.
I love hers.
Yeah, I'd done some sync training, got to train with Kathryn Shaker, got to take the EFS with Sue Thoiry. So, I took infant-driven feeding back in the day from Sue Ludwig and Kara Ann Weitzman. So I had taken, over the years, I took a lot of the basic feeding, but I would say almost all the ones I just named, I took in the first 10 years of my now almost 30-year career. So 10 to 15 years. So, I also took Kay Toomey's picky eaters, problem feeders, that class. Like, so there were a lot, there's so many more I could say, right? Now I'm like, oh, I'm forgetting Lynn Wolf and Robin Glass, like, right? All these people. So again, you go to these courses and you add to your own toolkit and your own knowledge base, and then you collaborate and share that with your coworkers. Because I actually mentored with Lynn Wolf and Robin Glass in 1999, and I promised their courses am identical 26 years later, right? So yeah. So I
We,
then, when other people I know have gone to their course, I'm like, what are they talking about now? Like, what's new? What's different? So
yeah, that's
yeah.
that's what I took a class a couple years ago, and oh my gosh, I cannot think of her name. And she was the first SLP that I saw really talk about like the pulmonary piece and like respiratory therapist. And then
Mm-hmm.
like 2 or 3 years later, there was all of these SLPs talking about like the respiratory
Right,
component
right.
for like infant toddler feeding. And I'm like, I know exactly where this information
Right,
started, but
right.
and then to go back and run into her at like an ASHA and I can see her face and she practices in North Carolina and it will come to me. But it's really neat to see the evolution in her course because she kind of broke the
Mm-hmm.
ground on it. And she was
Right.
talking about like expiratory muscle strength training and why we need to include that for like it's good for our adults, but for some of our peds patients with like cerebral palsy. It was really neat. Oh, that is going to come back to me probably in 32 minutes, but,
And
here we
well,
are.
and then you add, right, you just start to pull it together. I was fortunate to get to do the 8-week NDT course also
Ah,
many years ago, which is amazing.
neurodevelopmental training, is that what it is?
Neurodevelopmental therapy. Yeah,
Okay.
neurodevelopmental treatment. Sorry, I'm saying it wrong too. So the old BOBAF. Now I'm
Yeah.
really dating myself, but I got to take that, and then again, it's OT, PT, and speech, and so
Wow.
you're learning from each other. You're learning alongside each other. You're adapting strategies and thinking about how this is going to work. And sometimes you're the only person in the room, right? That happens too. I for a while, I'm sorry, this is gonna. There's going to be some listeners who don't love this, but for a while we did not have speech in our NICU, and so my PT counterpart and I were the ones going to swallow studies, and we were having the radiologist call the whole thing, but we could feed the baby, we could watch the study. I know how to feed a baby, those sorts of things.
But
So
that's
sometimes
the
you have to make do with
reality.
what you have.
Yeah. It's service that has knowledge and experience and skill. I mean, you're
Mm-hmm.
still offering something that's safe, but these are the barriers of the world that we live in when
Mm-hmm.
medicine is bogged down by entities and organization that may not have been trained in actual
Mm-hmm.
treatments.
Right.
Yeah.
Or you don't have the right people on staff at the time, whatever the reason may be. We also had I had a situation a couple years ago where we had a baby that absolutely needed a swallow study, and our SLP was out sick and from the NICU. And so I grabbed our outpatient SLP who did swallow studies all the time. And I said, we're going together. I will feed the baby. You'll be the
Yep.
SLP. We're like, you make it work, but I wasn't going to make the family wait, right, any longer. So
Yeah. Okay. So, but what does it look like? Okay. Please know
yeah,
I have
perfect.
never worked in the NICU.
Yeah.
Like, I cannot, my heart would shatter a million deaths. I had labor stopped 7 times with my oldest and
Oh,
14
wow.
times with my youngest, and did bear came at week 35, like on the day. And I had labored 2 weeks, 10 to 15 minutes for 2 weeks straight, the last 2 weeks of the pregnancy. And like he was the one that 6 pounds, 12 ounces, biggest baby in the NICU. But he was like a football and everybody else was
But you
like itty
stayed
bitty.
it.
I was like, it confirmed that I could never work in a NICU, just seeing and living my personal
Yeah.
experience.
Yeah.
So I will be the one asking the novice questions because I just couldn't be in there. But what does it look like for you?
So, in the NICUs I work in, we as PT and OT get involved from delivery. And so sometimes I literally, like, I'm not in the delivery, right? But I have been the one talking to dad because I'm in the same room and he's standing off to the side when they're doing the resuscitation of the baby. So we start as early as we can, I guess is the way I put it, without adding trauma to the family, right? Sometimes there are families where it's better to wait a couple days. But we start with parent education and support from the beginning, because we know even if a baby's born at 23 weeks, if we can get the parents more comfortable in at least talking to the baby, let alone touching the baby, it's going to be better for the baby. So we do a lot in the way of developmental care, positioning. Also, positioning, we know, the benefits for the musculoskeletal system, for the neurological system, for gastrointestinal, but we also have to think about skin for these little tiny babies.
Yes,
Go ahead.
when you say positioning,
Mm-hmm.
what I've seen kangaroo where they have them on
Yeah.
their chest, but what does that mean?
So positioning is whatever activity the baby's doing. So if they're in skin to skin, we want to make sure they're in good alignment as much as we can, make sure it's comfortable for the parent and the baby. But also when they are in the incubator, making sure that they are as well aligned as they can be, so that we are supporting the development of normal physiologic flexion, of their alignment, of the way everything in their body is going to work is partly due to that early positioning, that now they don't have the in utero confined space. They're working against gravity when they move. So trying to mimic the womb as much as possible.
And then they're tied up with like all of the cords, and yeah, I mean that's
They're connected.
I'm like, Bear didn't have that much, but he had enough that I'm having a moment over here on my head thinking like we first went in and I could just like touch him right here for like a
Yeah,
moment. And it was like, there's
right,
my baby's foot. And that
right,
was the most
right.
amazing
So a
sensation.
lot of what we do is support parents alongside nursing. So again, we're collaborating the whole time. I'm not going in by myself. I'm talking to the nurse. I'm checking in. When is RT going to go in and do their care? How can I go in at the same time to support the baby for that sort of thing?
That's amazing. And when do the pacifier dips and the bottles and the breastfeeding, when do those moments start happening?
So I like to think that breastfeeding starts at birth for two reasons. One, hopefully mom's holding skin to skin as much as possible. And that is helping her body start to understand what needs to start happening. And it also helps the baby know that this is where I'm going to be. And then also, hopefully, she starts pumping right at the beginning immediately. So whether it's, even if her baby's born 3.5 months early, right? Hopefully, she's going to start pumping, whether the baby's 35 weeks or 25 weeks, or even earlier. And so hopefully that transition is natural to breastfeeding. I don't mean to silo them, but I will for a minute, just to make more sense while people are listening. So if you're doing skin to skin routinely, and if mom is pumping, and so the baby's getting that smell of the breast milk and all of that, then hopefully the baby will just start to guide itself down to the breast. That's the most natural that happens. So somewhere around 33, 34-ish weeks, depends on myriad factors with these babies, medical status, respiratory status, et cetera, et cetera. Hopefully the baby will start to kind of look for the breast and nuzzle and suckle and start to play at the breast and that sort of thing. And so the first breastfeeding is with the preterm doesn't look like the baby latching on and taking milk, right? The first breastfeedings actually look like the baby just having positive experiences at the breast. Just like we think about with older kids, right? How do we even get them to the table having positive experiences before we try to get them to put food in their mouth, right? So
So
that same idea.
it makes me think of the attunement and attachment. Like
Mm-hmm.
you're teaching those, you need to look for these subtle cues. So I have my CLC. That was my birth. I thought that test was going to be a cakewalk. That test was a beast. But they talk about those first hunger cues for lactation, which is interesting because honestly, none of that was actually covered in my dysphagia class for to be a speech pathologist. That was all exclusively taught through the CLC coursework. Um, hence the need for continuing education. But um, what I find is that caregivers assume it's going to look a certain way, that the child will just demonstrate readiness. And it's teaching those early cues, those subtle changes, like flaring of nostrils that they might not like something, or uh, an open hand versus a closed hand for I'm in a state of readiness. But just what you said, a lot of caregiver education.
Mm-hmm.
Yeah.
Absolutely. And reassurance, right? Because No one
Yeah.
expects to end up with a baby born 3 months early. Like no one.
No.
Yeah,
No. I mean, it's not what you want. It's your um, arrival at Holland versus, Paris.
exactly.
So,
Exactly.
yeah. Y'all, if you don't catch that reference, it's a very famous poem. I'll add it to the show notes, but it's a beautiful analogy for a special needs caregiver's arrival and their walk in life. Um,
Very true.
okay, so
So
in
I said a lot of things in there, right? But I didn't really answer your question about an eval.
it's okay. We had a
So
lot of ground to cover.
yeah. So I will say, I mean, the first things we're doing are really more neurodevelopmental in nature. And then when you think about milk drops, there is quite a bit of variability among NICUs as to when they add those in.
Mhm.
Um, you can offer a pacifier to a baby well before 30 weeks, and some will go right for it and some won't. I mean, I'm watching for things even much, much earlier. Is the baby, sucking on their ET tube if they're ventilated, that sort of thing. Um, and we might offer the teeny tiny pacifier once in a while when they're on CPAP, right? And they're young and kind of watch their responsiveness, right? Make sure that it's comforting and not stressful to them, that it's a positive experience. Really what we want is positive experience. And then we in my unit we distinguish two different things. So there's what's called oral immune therapy, and that is really painting the oral mucosa for immune response. So that's the first 7 days of life, regardless of the baby's gestational age. So and that should be mom's own milk. And there's a lot of literature around that. So some units will use a Q-tip or cotton swab to paint. We decided that that felt too noxious, so we will use a syringe, knowing that we may have a little bit get swallowed, but the majority is going to just be in the mouth because the younger babies aren't going to, it's a tiny aliquot and they're probably not going to swallow the majority. After 7 days, we go into what we call therapeutic tasting. And that's when we will continue to do very small amounts. The younger the baby, the smaller the amount. Very small amounts of milk, hopefully paired with a pacifier. And that would be whatever substrate they're ingesting. So if it's mom's milk, that's prioritized. If they're only on donor milk, we'd use that. And then at some
Y'all,
point later on, transition to formula.
do y'all have a
If you,
donor bank?
we do.
Awesome.
We do,
That's
sorry. Yeah, we have a bank locally, and then we do use donor milk in our NICU.
That's spectacular. I know that's not something that's common practice across the country
Right,
consistently.
it's variable. We are very fortunate that we can use donor milk for any baby up to 7 days, even a term baby, and then we can use it for up to about 34 weeks for our preterms and extend it if needed.
Amazing.
Yeah,
So
amazing.
when I remember when we were talking about like my own pregnancy plan, I never had to have a C-section, but in the event of, they were talking about utilizing different secretions to uh, create that first immunity, putting them in eyes, ears, nose, mouth.
Mm-hmm.
Uh, do do they do that for other holes, or is it just, I don't know how to phrase that without sounding
No,
gross.
that's fair. Not typically. I mean, in the NICU, because breast milk is a bodily fluid, so we have to treat it like blood, right?
Yeah.
And so we just use it in the mouth. But that's fair.
I mean, the amount of times I've been working with other women in early intervention and then their babies threw up their breast milk like all over me. And I'm like,
Right.
they just change. It happens. It's life.
Yeah.
Yes.
Exactly.
And folks, if you're listening and you have not yet been christened, just wait. It will happen.
Absolutely.
That's
That said, I always say I'd rather be thrown up on by a baby than an adult.
yes. I heard. All right, so folks, before we started recording, we were talking about gross boy parents, and I saw this meme online, and I'm going to remember this for when they're teenagers. And it said, "The rules of the evening: do not add to the population, do not decrease the population, and do not get a permanent record." And I was like, "That's really good
Fair.
parenting."
Yeah,
We're gonna survive the boys being 11 and 13.
you
It's
are.
great.
You're going to.
But so when through this course, I know you referenced like coming in and doing the caregiver education and partnering with nursing when they're in there or respiratory when they're in there. How do you collaborate with the SLP?
Mhm. So because we do therapeutic tasting and we do some other kind of early oral stimulation to support the acquisition of feeding skills, our SLPs are getting involved as early as excuse me, as early as 28 weeks, depending on the baby. Especially if we're doing more of those pacifier dips. We also have another device that we can use that helps with training babies' sucking frequency and strength, and so they'll come in to support that. And that modality it's a fantastic addition, but it's not so much time consuming, but it has to be done twice a day. So there's absolutely room for OTPT speech to all be involved in that. And we're all assessing it a little bit differently and considering different things. But it also helps our SLPs to get to know these babies earlier and to have a sense of this kid loves the pacifier, but never stops to take a breath. This kid, we had to like work him into doing a pacifier. This baby can't even tolerate, the respiratory status is such that they really have trouble if they even try to suck on it. So we're starting to kind of lay the groundwork and educate parents at the same time. Like, this is what we think feeding might look like. This is how we're going to get started in case, those sorts of things. So just getting to know the babies can be really helpful.
Do you see consistency and patterns like your cardiac patients with these congenital heart defects present consistently, like increased work of breathing on even just a pacifier? Or do you see your little ones with maybe Down syndrome and low tone? Do they have like predictable patterns or growth in the NICU? I don't know if I'm asking that
Yeah, no,
question.
I understand what you're asking. Sometimes, that said, there's a lot of individualization. Um, so I feel like the one place where I feel like we can make some more prediction is around the babies that have pretty severe respiratory disease and how they do.
Okay.
So if they have true chronic lung disease and we're seeing signs of that early on, then we know that's going to impact feeding.
Uh-huh.
But they also tend to feed. They tend to start feeding later because they stay on higher supports longer. So
Yep. Yep. There's a children's hospital 2.5 hours away from where I live. And I've had a couple colleagues resign because they had like a carte blanche, regardless of essentially etiology. If the kid was on CPAP, they still wanted them doing oral feeds. And that just kind of blew my mind because I thought the literature counterindicated that. Now it was PICU, not NICU, but I mean, some of them were like NICU grads. But do y'all have any like, this is a stop, we're not doing oral feeds because of this, and this? What are your criteria?
So, we go by what the baby's telling us. We go by the baby's cues, but we do what we tend to do. There's always gray. We tend to do what a lot of units do, which is not feed over 2 liters in the NICU. And I clarify that because the bigger the patient, the higher the high flow can go and still be considered safe. We do have times where our providers will encourage us to assess the baby and see if they can feed above 2 liters. And we'll do that on kind of a, case by case. But again, it has to be, that's where getting to know the baby can be so incredibly helpful, right? If I
Yeah.
have a baby who is desaturating with a pacifier, I'm going to go to the provider and say, I don't feel comfortable trying a bottle, right?
Yeah.
Versus the
Advocacy.
baby, yeah, who's rock solid. And yeah, so it just depends. It also depends if we're working on breastfeeding. It depends on the baby, but then it's going to depend on mom too. Because if I have a mom that has almost no milk supply, then I'm going to be like, sure, go ahead, see what happens, right? But
Yeah.
if I have a mom who has, breastfed older siblings and has a really incredible supply, I may have her pump some first so that the baby doesn't get such a flow or doesn't have to deal with letdown. Or so it's gonna depend on really assessing factors about, at least the baby and the mom if we're breastfeeding, and then how do you make sure it's safe and comfortable for the baby, right? I think one of the things that happens in the NICU is we forget that feeding is social and
Yeah.
fun and celebratory. It's not just a task. I mean, hopefully we don't sit down 3 times a day and shovel food in our mouth because it's 8 a.m., noon, and 5 or whatever, right?
I'm so sorry, I'm laughing so hard because this is a running family joke. My husband was in the army, and my
Oh,
oldest, they both eat like they sit down, you consume, like it's gone, like it was there and then it's gone, and I'm like, whoa, 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 conversation, like the social and
you
stuff.
know what you just ate? Yeah.
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 So
I mean, if you think about cultures around the world, right? We eat food at holidays. It's
yes,
fun. We eat food at parties, right? Like, and I'm not saying it should always be like that, but it shouldn't just be, I'm going to sit down and tune you out and feed you 8 times a day and hope for the best.
yeah. No, that's when, but again, attunement and attachment, and that's where we get early language opportunities, like
Right.
wearing the SLP hat.
Yes.
That's the moment to say, okay, do you see how your baby's looking for you? Do you see
Mm-hmm.
how their hand is reaching for you? That's, they want you. Or yes, they're crying, but that cry, what does that pitch or tone? Do you hear the difference
Exactly.
in this? And it's that early language. There's, oh,
Right.
it's
Right. And
beautiful.
I mean, to that point, babies at 34 weeks can have conversational turns, right? They can be
Yes.
responsive. So we owe it to them to be responsive to them.
Yep. I Bear used to be comforted and Goose by Chewbacca noises because in utero, my husband used to growl at them like Chewbacca. Hence, we had a dog named Chewbacca. He is since passed and is currently residing in his box on the fireplace mantle. Uh, but they remember these sounds. So I know when I get them in early intervention and they're in NICU grad, I'm like, what did you sing to them? What did you talk to them when they were in your belly? Like, let's recreate those sounds for comfort because those memories are there. But yeah, yeah.
Absolutely.
Now,
Yeah.
I do have to ask a question that our little ones that have neonatal abstinence syndrome or have
Hmm.
had exposures, how do they present the same or different than peers that were born early because of other etiologies?
Hmm. So we typically now refer to it as neonatal opiate withdrawal syndrome.
Oh,
The
wait.
one
Okay. Tell me.
instead of neonatal abstinence. And the simple way to understand that is the baby doesn't choose to abstain. The baby is going through a withdrawal process because of what they were exposed to. That said, the problem with that term is there are things they will withdraw from that are not opiates
Yes.
or opioids. So if we use a term NOWS, neonatal opiate withdrawal syndrome, if we use that term, what do we do about the kids that were exposed to methamphetamine or SSRIs or kratom or whatever else is out there, right?
I don't even
Um,
know that last one that you said,
kratom
kratom.
is it's a herb. It's a plant from Southeast Asia. People smoke it. You can anyway. It's completely unregulated, um, and it acts like an opiate in the nervous system, basically.
Oh,
So people will use it to prevent withdrawal if they're trying to go off of opiates or opioids. So,
okay.
um, but without getting too far in the weeds, right? Or they're exposed to cannabis. Like there's all these different things, alcohol, right? So the problem with that term is it doesn't get to everything. But if you have a baby going through withdrawal process, regardless of what they were exposed to, um, there are a few things we tend to see. They tend to be more term age. One thing that's key to note is if you have a preterm baby, like especially under 30 weeks, but under 28 weeks, they typically will not go through withdrawal even if they were exposed because they don't have enough brown fat. And that is where those are stored and metabolized.
Okay.
And so the younger the baby, the less likely they are to go through the withdrawal process. There's always exclusions. And the same is true if you have a baby that has had a whole bunch of surgeries and had to be on, morphine or fentanyl or what have you in the NICU, they may go through some withdrawal stages as well. So
Right.
there's a
Okay.
lot of crossover in symptomology. But all of that to say, I'm gonna put fentanyl on the side for a minute because fentanyl has changed the picture. And one of the units I work in, we have a fairly large population that have gone through withdrawal, and we were early adopters of Eat, Sleep, and Console, which is the newer framework for how you support these babies through their hospital stay. Ideally, they're with their parents, they're being held, they're being offered a pacifier, and feeding kind of comes along with their nervous system regulation. If they don't have that and they are dysregulated, then feeding becomes more challenging.
Okay.
And that's kind of where fentanyl comes in. So fentanyl has caused greater dysregulation than we've seen from any of these other substances. Moms often don't even know they were exposed because it's cut into so many different things. So they may have no idea that they were taking this, that they were ingesting this and exposing their baby to it. And the majority of babies exposed to opiates in particular will have what's called hyperphagia, where and it's just like it sounds, right? Where it looks like they're looking for the breast all the time. They want to suck all the time. And so what can happen is they can inadvertently be overfed and then have GI distress from that, right? Or have reflux from that. So we have to be a little bit cautious about that. Fentanyl has it's changed the scene in that the babies appear more neurologically impacted. And so I have personally worked with several babies who cannot even show us a reflexive suck at the beginning.
Oh my God.
And so what I always say is if they can't take a pacifier, we're not going to do well with bottle of breast yet, right?
No.
So,
But
and
that
again, these tend to be term kids, right? So if a term baby cannot even take a pacifier, then we're not really going to go anywhere until that happens. And that's where you have to collaborate with your medical team. You have to collaborate together. We work OT, PT, speech. We work together on feeding, but also regulation and sleep. And how do we support the baby and the family to kind of get through these early stages to get to feeding? So
are they treating these babies with any medications to like help
it
them?
depends. It depends. That's the answer. So it used to be before Eat, Sleep, Console, which people can look that up if they want.
Yeah.
Dr. Matt Grossman was the one who started that on the East Coast. It's been fantastic. It definitely reduced length of stay because these babies didn't need the pharmacological support. They were calming with holding and pacifiers and really a lot of parent engagement and support. And so the problem is if you give a baby morphine, then you have to titrate them off, and that can take weeks. However, if the baby is so dysregulated that you can't do things like feeding, right? Whatever the skills are they have to gain to go home, then they may need medication to get to that point. So I know we've been struggling in our own unit. Do we treat them pharmacologically so we can start working on feeding, knowing we're increasing length of stay? Or do we wait till they're ready to start feeding without pharmacological support, knowing that that's going to increase length of stay? So it's a hard one.
Yeah, but then I have to wonder the follow-up question of theoretically getting these babies out the door also relies on a caregiver learning those skills alongside so that they're safe for
Yes.
discharge. But then do these little ones go home with their birth mother or family because of why they're there, or are we relying on additional different family members or foster care system?
That is
So,
very location dependent because all of our states have different regulations and laws and practices. So
oh,
that's a big question. Yeah. And some families are very motivated to become the caregiver and to do whatever it takes to be the primary caregiver. And some are not there. They don't have the capacity right now to do that. So yeah.
yeah. Social supports, having a good social
Yeah.
system there that can help them.
Right.
It's like Maslow's scale of hierarchical need. If they don't have
Exactly.
the base of their pyramid, then everything else
Exactly.
will follow down. Yeah.
Exactly.
Okay, so on that note, folks, if you yourself are struggling with addiction, or if you have a loved one that's struggling with addiction and you don't know where to begin, there's a really good website called findhelp.org. And you just put your zip code in, and it will pop up some of the craziest resources that you don't even know exist or are an option. And it's just a great site for free information. on a lot of different things from how can you pay your power bill this month? If you need support with like natural gas, it's going into winter here in the mountains and we have a lot of propane out here. So that one popped up into mind, but
It's amazing.
yeah. Okay. So we get these babies and best case scenario, everything's plucking along. How does the team work together? Like,
Yeah.
do y'all have rounds? What does this look like on a
Yeah.
day to day?
So we do have rounds, and then we communicate with one another very closely. So, like one of the things we've done in our in the EHR where I am is we make sure, because OT PT speech work so closely together, we make sure that we can see each other's kind of daily updates, right? And also, like, what are we doing next? We want to make sure I can see what speech is doing, vice versa. Um, and then we'll triage patients based on their needs. So if it's a baby where I'm already doing a lot of, like say it's a baby with Down syndrome, so I'm working on musculoskeletal intervention, I'm working on, posture and these other things, I might keep feeding for longer. But if I feel like it's true dysphagia, then I'm going to pull speech in 100%, right? If I
Yeah.
feel like the baby has swallow dysfunction or we're heading that way, I want speech to be looking as well. I don't want to be the only one managing that. If I have a 31-week baby who's now 35 weeks, they're working on breast and bottle feeding, things are kind of just going along as we would hope, maybe we don't bring speech in, right? Maybe we save their time for these other babies that are going to need more of their time and attention. And I just keep following that baby unless I need more support, that sort of thing. So there's definitely a place. We also have a big enough team that we can play off each other. And I am a very direct communicator. Not all my teammates are. So I might have one come to me and say, you need to go talk to this family. Like, they need your approach. And I might realize that this mom, I'm overwhelming her. And so maybe I'm going to ask my colleague to go in, right? So
I love
we play to our strengths. I have one OT in our NICU who has done a lot of work with kids with autism for years. If we have a parent who is on the autism spectrum, I'm going to pull her in to work with the family because she'll probably respond to them more skillfully than I might, right?
Yeah.
So again, if you have that, that's ideal. You don't always have it, right? You want somebody who's on vacation or whatever, but yeah.
We I struggle with caregivers that are incredibly direct. Like that always overwhelms me. And I think it's because I was just Southern enough that here's the point, and we're going to get to it, but we're going to tell you 14 stories before we get there and take a detour or two. But that when they're very blunt, I'm like, oh, okay. And anxiety. But that's the irony being SLPs are not always the world's best communicators.
No, I mean, again, it's all, one of our hospitals is right on the edge of what we call the Silicon Forest up here, which is, a takeoff of Silicon Valley in the Bay Area, but we have the Silicon Forest. And I can work real well with a lot of engineering parents, right? Like it just, again, you make it work. Yeah.
Yes, yes. Okay, so can you walk us through a case study uh, and just kind of, HIPAA compliant, of course, but
Sure.
walk us through a case study from like, this is what brought the baby in to the NICU. That would be lovely.
Sure.
And it's always, if they are bottle fed, for those of us that are on the outside, it's always helpful to learn a little bit about why nipples were selected or like that particular tool was used.
Sure. So, so I have worked with a few babies like this, so it won't be anyone, I promise. But we have a few times had a baby that was born preterm, and somewhere around, and let's say 27 weeks, I'm just going to make something up, somewhere around 32 weeks, sometimes earlier, sometimes around when, for one baby, it was when CPAP came off and you could really get a good look at the face. The baby had Down syndrome, but it may not have been picked up immediately. So it might be a baby.
What?
So when a baby's born preterm, the features are not as easy to distinguish if there wasn't, prenatal testing that showed Down syndrome or trisomy 21, the parents may not know, right? Sometimes it's not diagnosed till after birth. Sometimes in preterms, it takes several weeks before someone's like, something's off here. And I've seen that with other genetic diagnoses and syndromes where, I remember one baby who was born around 28 or 29 weeks, and the nurse kept saying, I don't know, her tone just seems really low. Like, I know she's preterm, but her tone seems really low. And she did have a different genetic disorder that showed up once they started testing. So again, this is the benefit of getting to know these babies, right? And kind of seeing what they're doing. So let's say preterm, OT and PT are already involved. They're already supporting, musculoskeletal interventions, neurodevelopmental interventions. We bring speech in to start doing some of the pre-feeding, parent support around that. We also do infant massage with all our babies, and our SLPs do that as well. It's whoever, has the schedule, quite frankly, that matches up with mom and dad can teach that. And so then, toward between 32 and 34 weeks, baby starts queuing. We start, doing some trials at breast, that sort of thing. And then we often start bottles, not immediately, but within several days of some of those early breast opportunities, because most babies from the NICU will go home hybrid. We have very high rates of breastfeeding and breast milk use where I am in the northwest part of the country. But again, most babies are going to go home with both and then continue to work on breastfeeding as the baby matures at home.
So hybrid means bottle and breast.
Sorry, meaning bottle and breast. Yeah. Okay. And I will often say to NICU parents that, breastfeeding in a term baby that comes out and nurses right away, it still takes a month for a new mom to feel comfortable breastfeeding that baby, right? And for the baby to really be skilled, at least a month, right? So
yes. Yeah. And shame moment, or like letting go of shame. I remember, right. This is my oldest. He is almost 13, and I had never taken a CLC class. I wasn't there professionally, I was only a couple of years out. When the first time he went to latch, I must have made a face, and the lactation counselor, I had just given birth like an hour or two ago, and if that, and she goes, "What is it?" And I was like, "I'm pretty sure that's how we got in this position, because nipple foreplay counts." But to go from that to this is what it feels like when you're breastfeeding. And I will never forget the shame that lactation counselor made me feel for saying that out loud or feeling that way. And I worked when I was actually getting my CLC. One of the other women, the educators in the class, she was like, you got to remember, a lot of these parents are trying to reprogram their brains for these sensory inputs, and validated that for me. So that's something that, so if you're thinking about breastfeeding, heads up, because it's going to take a minute to reprogram your own personal hardware. Yes.
And I use analogies all the time when I teach, but we don't live in cultures where we're with our moms and our grandmas and our cousins and our aunts and our sisters and our whatever. We're not around breastfeeding like that, right? Like when we were in that kind of cultural scenario. And so that's why we have IBCLCs, right? And that's why we have these people in the community to help. Babies don't just pop out and go to the breast and everything goes swimmingly all the time.
Correct. And it's going to hurt. That's what the piece that it doesn't hurt like you're tearing skin off. Well, sometimes it can, but
it's uncomfortable. It can be uncomfortable initially. Absolutely. Yeah. So I will say to NICU parents, we give any term baby a month. So we're going to give you a month post-term, and your baby's only 34 weeks or whatever, right? And the point I'm making there is the breastfeeding is typically not fully established when the baby goes home from the NICU, which is why we're going to use bottles and breast. So to your point about what do we use and what choices do we make, I will say that full disclosure, I also work for Dr. Brown's Medical in addition to working for the hospitals. And so I am very familiar with their products, but I also use their products in my NICUs. That's what we have available. So we typically start with Dr. Brown's with a preemie nipple, and then we always say we can go up or down as the baby, based on the baby's performance. So a baby like this, we would fairly quickly go to an ultra preemie, or we might even start with an ultra preemie, because if we're talking about a former preterm baby who also has lower tone, we're going to want to be cautious as we approach feeding.
Yes.
So making sure they're well positioned in sideline and that they have good head and trunk support, so that I always say we want to get this as well aligned as we can. Sorry, and I'm pointing to my head and my neck over my shoulders so that the baby can put as much energy toward their mouth as they possibly can, like to, you know, preserve that energy for their oral motor function. And then depending on what the baby's doing, and the reason I use this example of Down syndrome is because sometimes those babies with lower tone will do better with a wider nipple as opposed to a narrower one. Just they get a little bit more stability, they get a little bit more sensory input. And so one baby I worked with where it was a little bit challenging because there is no ultra preemie nipple for the Dr. Brown's wide base. So these were very skilled parents, and I was literally helping them kind of position the baby in the bottle so that we could decrease the flow of the preemie nipple, but use the wide base. But that's real tricky, and I would not try that with every family.
Yeah.
The baby that I kind of have the picture of in my mind ended up doing well with that setup, well enough that they progressed to where the preemie flow was fine, went home on that wide base preemie with mom still working on breastfeeding. And then this baby where we were doing a lot of support around feeding, we're going to get them set up with outpatient, typically speech 1 to 2 weeks after discharge. But then we might tag team even on the outpatient side, because a baby with a musculoskeletal, you know, with a syndrome that has musculoskeletal implications like that, PT is probably going to see once a month. So we would prioritize to one of our PTs who also works in the NICU and does feeding. And that way speech could follow, and then PT could alternate and kind of do a feeding check-in at the same time, adding another speech visit in as needed. So that baby we were able to do, you know, SLP 2 weeks after discharge, PT 4 weeks after discharge. At the 6-week mark, it was SLP again. At the 10-week mark, it was PT again. Or even at the 8-week mark, it was PT again. So kind of alternating, but working together, checking in with one another.
Do you know if they discharge into your local early intervention system as well, concurrent to? Beautiful.
Yes. And unfortunately, we have a hard time with feeding support for these littles in our early intervention setting. It's improving, but that's just typically not the strong suit of the EI providers, is what we've found over the years.
Yeah.
The feeding piece in particular.
Yeah, it's hard to find. Full disclosure, I now work full time, but full time is still only 4 days a week because it's the way the contract is set up through it's EI, but it's through the public schools. And so, you know, the way this system runs, we even have OTs that do feeding. But back home in South Carolina, it was you struggled to find somebody.
Yeah.
So it was often that, you know, yes, you had a referral to early intervention, but they might get PT and OT or maybe just PT through the EI system and then have to go to a nearby hospital for an outpatient clinic to continue with feeding services or specialty clinics. Also, I don't know. I went down a rabbit hole last summer when I was working on a Down syndrome presentation, actually for Feeding Matters. But there's new research out now that the trisomy 21 actually triggers decreased collagen production in the body at the cellular level.
I have not heard that. That's fascinating.
Yep, because now that they have, and they're attributing the decreased collagen to the severity of the hypotonia. So now that they've pegged that, I thought you'd think it was neat because now
that's amazing, and that would explain a lot, right?
Yes.
The other thing, and I only learned this a few years ago, is they have a much higher incidence of submucosal cleft.
Yes. Yeah.
Or not submucosal. Sorry, laryngeal cleft. I meant to say laryngeal cleft. I apologize.
It's okay.
Laryngeal cleft. So making sure, you know, if we're seeing dysphagia, is it swallow? Is it laryngeal cleft? Is it right? Because
And folks, laryngeal cleft has 4 grades, but the trick is it's oftentimes just that tiny little one, that level 1, where it's like a dip, almost like right at the thyroid notch. And what's tricksy is that doesn't always show up on the first scope because of the nature of inflamed tissue and hypotonia at baseline,
And the
everything
size of the airway and that, yeah.
yeah. And then you're like, okay, but is it laryngomalacia, trachomalacia in addition
Yes,
to? And
exactly.
I had one little guy, bless his heart, he had his adenoids removed 5 times over the course of us working together. They kept growing back. And the mom was like, by the 5th, she was like, I'm pretty sure this should just be free. But laryngomalacia, trachomalacia, laryngeal cleft, and vitamin D deficiency. And it took all of these variables, and now we're right as rain. But like, oi, that's a lot. So,
Yes.
yes.
Yeah. Think
But
about what that poor the child and the family has gone through, right?
yes,
Yeah.
but
Wow.
he does rock a good mohawk. So, but folks, this is why you have to know, yes, that baby's there. But the reason why I asked all these questions about like primary etiology is that there's corresponding literature on additional comorbid diagnoses that will influence who you pull in on your team um, and treatment. So, yeah. Oh, well, this is fun. Okay,
No, I feel like
so
we could just keep talking for hours.
we could. I'm like, well, this is great. Okay, so folks, please know I literally time our podcast episodes and recordings around Waffles, who has, knock on wood, been quiet, but also the school bus getting home. So I just Bear's getting ready to come in. So before we have a joyful, wonderful distraction in form of my
Yes.
second tiny offspring, um, if folks are listening and they want to learn more about PTs, or if they are just afraid of collaborating, do you have any words of wisdom for them?
Absolutely. I think I would say a couple things. I think we are always stronger together.
Yeah.
That's whatever we do in life, right? One can carry a burden, but two can carry it better, right? And I'm not saying that this is a burden at all, but that's true. Like joy is awesome when you're alone, but joy is better when you're with other people, right? So we need to support one another. We need to work together. I have one brain, right? I'm never going to come up with everything I can possibly do to support a patient. So that's where I love my collaboration and my opportunity to work with other people. But I'm also happy to connect with people. If they want to talk about it more. I've been doing this a long time. I've been able to do a lot of advocacy in our field. When I first started in the NICU, we were called in at 38 weeks to fix the baby that needed to go home in 3 days, right?
Oh my God.
And now, now I have met 22 weekers within hours of birth. So I'm very happy to talk through that journey with anybody as well.
Awesome. Okay, so how do folks reach you?
So they can absolutely email me. The best way is at my Providence address, which is just my first name dot my last name. So Kati.Knudsen@providence.org. And I assume they'll be able to see the spelling of my name on the podcast. So yeah, or you can reach out to me on LinkedIn. That's another great way. I'm on there more than I should be.
Same.
So feel free to get me there too. Yeah, whatever's
Amazing.
easiest.
Okay, so if somebody feels moved, and as my grandma says, maybe they got a little love money or a little mad money left over at the end of the month, is there an organization or an entity that they could support after listening to this?
Sure. I love babies. I love preterms. I think one place where we need to continue to do work around advocacy is for the moms and babies with substance use disorder. So we have a local center in Portland called Letty Owings Center. That's one. But honestly, if there's one in your community, support that one, because we know it's an ongoing issue everywhere. And to your point earlier about, with cuts to social programs and insurance and all these things, these places are going to not have the funding that they have had historically, potentially. So,
Yeah.
yeah.
So, everybody, I know we're battening down the hatches from budgets everywhere, but a little love money can go a long way, or volunteering there. So, yeah,
Absolutely.
yes. Kati, this was lovely. Thank you so much for the work that you do, for the advocacy that you do. But I truly appreciate you coming on. So thank
Thank
you.
you. Thank you for having me.